Pediatric Cardiology Today. My name is Dr. Robert Pass, and I'm the host of this podcast. I am Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai, where I am the Chief of Pediatric Cardiology. Thank you very much for joining me for this 286th episode of the podcast. I hope all enjoyed last week's episode on the topic of the Harmony TPV25 valve and the finding of increased intimal proliferation in some valves. For those of you with an interest in interventional cardiology and specifically transcatheter pulmonary valve replacement, I definitely recommend you take a listen to last week's episode in which we spoke with Dr. Zachary Steinberg of the University of Washington. As I say most weeks, if you'd like to get in touch with me, my email is easy to remember. It's pediheart@gmail.com. Before we move forward to this week's work, I'd like to take a moment to mention that this past week we reached an extraordinary milestone for the podcast when we achieved over 1 million downloads of Pediheart. I must admit that I never imagined when I started this that the podcast would reach so many people, and all I can say is that I thank you for listening to the podcast, and it has been a joy to help share some of the latest and greatest in our field with all of you, hopefully shining a bright light on some of the extraordinary people in our field who toil day after day, both clinically and in research. Thank you so very much for your support. I'm not sure we'll ever reach 2 million downloads, but I did wish to thank all of you who've been so very supportive. Thank you very much. This week we'll be moving on to the world of interventional cardiology once again, and the title of the work we'll be reviewing is Technical Success and Serious Adverse Events for Fetal Aortic Valvuloplasty in a Large 20-Year Cohort. The first author of this work is Ryan Callahan, and the senior author Diego Porras. When we're done reviewing this paper, I'm hopeful that Dr. Callahan and Dr. Wayne Tworetzky, who is a co-author of this work, will be able to join us together to speak about it. Therefore, let's move on to this wonderful article and then a conversation with its authors. This week's work is on the topic of fetal cardiac interventions, and specifically fetal aortic valvuloplasty, something we have been hearing a lot about in dribs and drabs over the past 2 decades. The work starts with the comment that severe aortic valve stenosis in fetal life can risk progression to hypoplastic left heart syndrome. And then they state, and I'm quoting because I wish the listener to know that this is the author speaking and not me, a technically successful fetal aortic valvuloplasty can avert some of the anatomic and physiologic consequences of severe aortic valve stenosis and can increase the probability of a postnatal biventricular circulation, close quote. I quote this because though the authors have published some work suggesting this very fact, I think it would be fair to state that there is perhaps some controversy, or perhaps more accurately, the role of this procedure is not yet fully established. The authors explain that the first fetal aortic valvuloplasty was in 2000 at Boston Children's Brigham program, and since then they've performed over 150 in the subsequent 20 years for aortic valve stenosis. And though they've had a few papers on this approach come out over the past 20 years, in the recent past, the authors note that a comprehensive assessment of the technical outcomes of this procedure, as well as factors associated with technical success and serious adverse events, has not been reported recently, though they have done so previously, as have others. With this as a background, the authors state, and I quote, "The purpose of this study was to report the rate of technical success and procedural serious adverse events in all fetuses who underwent the intended procedure of fetal aortic valvuloplasty for aortic valve stenosis at the Boston Children's and Brigham and Women's Hospital Fetal Cardiac Intervention Program, and to determine which fetal and procedural characteristics are associated with fetal aortic valvuloplasty technical success as the primary outcome and serious adverse events as the secondary outcome. The evolution of the procedure over the last 20 years as it relates to the fetal cardiac invasive team is described." This was a retrospective work reviewing all patients in the Boston program undergoing an attempted fetal aortic valvuloplasty from March 1st, 2000 till December 31st, 2020. The authors differentiate between those who planned to have a fetal valvuloplasty, which were basically the intention to treat patients, versus those who had an attempted one, which was defined as the operators attempting to place the LV cannula into the LV. For this work, the primary outcome was technical success of a fetal aortic valvuloplasty, and this was defined as positioning the balloon across the aortic valve, dilating the valve with improvement in antegrade flow, or the development of new aortic regurgitation. The secondary outcome was the occurrence of a serious adverse event, which for this work was defined as intraoperative bradycardia or ventricular dysfunction, pericardial effusion needing a pericardiocentesis, aborted fetal cardiac arrest or fetal death, which was defined as an intraprocedural or periprocedural death or preterm delivery of a non-viable fetus. The authors divided the procedures into two time periods, the earlier period being the first 10 years from 2000 to 2009, and the later period from 2010 to 2020. They review the many data used in this work, including the characteristics of the fetus, like gestational age, size, and all the many varied fetal echo parameters. And for those interested in those details, certainly I would recommend going and reading the paper. The authors then review the actual procedural considerations, and there's a nice figure 1, showing the equipment used as well as an echo that very nicely demonstrates balloon inflation in the actual aortic valve. The technique is described on page 3 of the manuscript, and the authors explain technically some of the issues that they've been dealing with, notably the lack of availability of their original 19-gauge introducer and the small coronary balloons that they were using through that introducer, and how they've changed to a new biopsy needle by Bard and are now using a different coronary balloon that is 3.5 millimeters in diameter, but which can be overexpanded to achieve an approximate 4.1 millimeter diameter if needed. The authors explain that they use the Voluson E10 by GE as their preferred echo machine, and again I would strongly recommend that those interested in the details of this procedure and how the Boston team performs it to go to the paper. And on to the results. There are many data in this work, and as I normally suggest, please consider reading this paper, and as always, the DOI number will be in the show notes. However, to summarize the more important findings, there were 165 fetal aortic valvuloplasty attempts in 163 patients, and the median gestational age was 24.6 weeks, with an interquartile range of 22.9 to 27.1 weeks. The procedure was technically successful in 85%, and when the investigators compared outcomes in the first era to the more recent era, perhaps not surprisingly, the technical success rates were higher in the more recent era, 94% versus 75% in the earlier era. And what about serious adverse events? Well, there were 117 of these in 67 fetal aortic valvuloplasties, or in other words, they were seen in 41% of the patients. Of these, 13 were fetal deaths, meaning that 7.9% of those undergoing this intervention died periprocedurally or shortly thereafter. And were there any factors that were associated with a higher chance of technical success? Well, yes, the presence of a larger LV long-axis dimension with a z-score over 0.10 or a higher LV ejection fraction, as well as more recent era, were independently associated with a higher odds ratio for technical success, and these features are summarized in Table 4 of the paper. And were there any factors associated with the development of serious adverse events? Yes. In multivariable logistic regression model that corrected for gestational age, fetuses with an LV end diastolic volume less than 4.1 milliliters had an age-adjusted odds ratio of nearly 5 for experiencing a serious adverse event. For those reading the paper, there's a great central illustration that very nicely and succinctly summarizes these results, showing that technical success was associated with increased LV size and higher ejection fraction, and serious adverse events associated with smaller LV size and longer procedural times. In their discussion, the authors state, and I quote, "Our current study, the largest of its kind, found a high technical success, which improved in the recent era. Larger fetal left heart structures were associated with a higher probability of a technically successful fetal aortic valvuloplasty. Regarding adverse events, serious adverse events were common, 41%, but most were treated without fetal loss. Overall, fetal death rate was 7.9% and improved from 12% to 4.4% in the recent era. Younger fetuses with smaller LV chambers, independent of age, and longer procedure times were associated with having a serious adverse event." The authors discuss how having a consistent team was very important for technical success, and how procedural time was lower in the modern era, and how this was associated with success rates similar to other reports elsewhere of this procedure. They review how their prior works on this topic also demonstrated many of the positive features associated with better outcomes for this procedure, and review a bit about why a bigger LV is likely associated with better outcomes, and how this may be due to the presence of an adequate distance from the LV apex to the valve to allow for space for the cannula, and space to manipulate a wire across the valve. they do not have a great understanding of why lower ejection fraction is associated with worse outcomes. The authors discuss the fact that smaller fetuses and longer procedural times were associated with higher serious adverse event rates, and how suboptimal fetal positioning with difficult ultrasound visualization and smaller hearts are all likely contributors to this higher adverse event rate. And they wonder aloud if they should consider a time limit on how long they try before aborting, given the association of longer procedural times with serious adverse events. In regards to limitations, they point to the retrospective nature of this single-center study. They review the limitation of the absence of a central lab for echo evaluation, and also how there are no data in this work on postnatal outcomes, and so the authors are unable in this work to connect these procedural outcomes to postnatal ones, which is of course the ultimate question here. They speak of how a prospective trial with a non-intervention control group would be important in future study of this approach. And so they conclude, the experience of a consistent multidisciplinary team and selecting ideal patient candidates has led to a high technical success rate in the recent era. Serious adverse events were frequent, 41%, but fetal deaths were uncommon. Fetal left heart size is an important factor in understanding both technical success and the probability of a serious adverse event. Well, this is an interesting update from the team in Boston about their results of fetal aortic valvuloplasty. It certainly appears as if the team has figured out how to get these procedures done in a relatively safe manner, though there remains a 4 to 8% fetal demise rate. As the authors themselves hint, ultimately, the real question about this approach is what happens to these patients later. This work does not answer this question, nor does it try to. Given the smallish number of these cases and the extreme variability of outcomes, I think this will remain a difficult question to answer, as the so-called devil is in the details. How many didn't have aortic stenosis after birth? How many had two ventricles with the LV as the systemic pumping chamber? These are just a few of the many, many questions that I'm sure a lot of you wonder about in this regard. It seems clear that this approach is not the panacea that it was initially hoped for in averting the development of hypoplastic left heart syndrome, but there are, of course, many gradations of gray in this, and so the notion that the authors suggest of a prospective trial seems to possibly be the only hope to really determine the absolute efficacy of this approach in a fair comparison. In the interest of time, I think it would make sense to move forward to our conversation with the work's authors. Joining us now to discuss this week's work are two of its authors, Dr. Ryan Callahan and Dr. Wayne Tworetzky. Dr. Callahan is a graduate of Drexel University College of Medicine, and he completed his residency in pediatrics as well as fellowship in pediatric cardiology at the Children's Hospital of Pittsburgh, followed by interventional cardiology fellowship at Boston Children's Hospital. He worked there for a number of years before changing teams to the CHOP Squad, where he is an active interventional cardiologist and assistant professor of pediatrics at the Perelman School of Medicine at the University of Pennsylvania. He's also a former guest on the podcast from back in 2019 when he spoke with us about Boston Children's experience with adjunctive biological inhibition agents in the management of intraluminal pulmonary vein stenosis, way back in episode number 18. Also joining us this week is the director of the fetal cardiology program at Boston Children's Hospital, Dr. Wayne Tworetzky. Wayne is a graduate of the University of Stellenbosch in South Africa for medical school, followed by residency in Cape Town at Groote Schuur Hospital. He repeated his residency at UCLA, followed by fellowship at UCLA, before joining the team at Boston Children's Hospital, where he is clearly one of the leaders in the world in fetal cardiology, and in particular, fetal cardiology interventions. It is a major coup for us to have both experts on the podcast together this week. Welcome Ryan and Wayne to the podcast. I'm here now with Dr. Ryan Callahan and Dr. Wayne Tworetzky. Real treat to have both of you on the podcast this week.
Pleasure to be here. Thanks so much.
Yeah, Rob, great to be here. Great to see Ryan.
Thank you. Agreed. So, guys, first question I wanted to ask, at the start of your work, you mentioned a distinction between planned versus attempted fetal aortoplasty. I wasn't sure from the paper, though, that I could ferret out what percentage of patients actually went to the OR for the intention of a fetal dilation, but didn't actually get one. I'm wondering how common was that, and what were the most common reasons that patients who went to the OR didn't actually get one? Was it usually just fetal position? Did the numbers of planned cases that didn't become attempts change with experience? I'm sorry, Wayne, maybe you could answer that since that's more in your ballpark.
Okay. So, it's important to note that there has absolutely been an evolution of our understanding of the disease, the technical aspects, that being the obstetric aspect, imaging aspect, catheter aspect, over the past 22 years. To specifically answer your question, planned meaning we took the patient to the operating room with the intention of doing the procedure, and if it was not attempted, meaning a needle was not even stuck in to attempt to access because of fetal position. Usually that's I'd say that's probably the only reason. And that is one of those things that sometimes you get lucky, the baby's in good position, and sometimes it's not. And that's, our obstetricians have been fantastic about positioning fetuses. Sometimes it's just impossible. So I would say it is quite infrequent that happens. I believe there were only 2 of those cases in the paper. There might be another one, I'm not sure, but it is very, very infrequent. And I'm not sure about those 2 specific ones, but often we'll go back the next day or a few days later and do it successfully.
And I guess that the reason that is so rare is because you're very carefully screening them before you even bring them in the room, I'm guessing. Yeah,
and I would say in retrospect, some of the technically unsuccessful ones were probably patients that we shouldn't have, in our early experience, that we probably shouldn't have even stuck the needle in. It was just one of those things where, until there's been an evolution of techniques, and Ryan can probably speak to some of the, cath techniques and their evolution. But, there probably have been attempts in our early experience where we in retrospect, shouldn't have tried because of the fetal position and probably led to unsuccessful procedures.
But to your point, it really is the end of a very long, comprehensive evaluation. Wayne vets these patients before they come to Boston. Most are, national referrals. Most are time sensitive. Like we have to get it done, within 1 week. And so you can imagine all the massive effort by Wayne and the team to kind of coordinate getting the family here, getting insurance approval, getting provider availability, which I'm always impressed that we're always able to kind of come together and get it done. And then when they do come, we get their own echo, and then all the providers see the patients, from fetal cardiology, MFM, and interventional cards. Everybody reviews the data and then agrees to proceed. So, there's a lot that's happening even before coming to the operating room.
Must be a logistical nightmare. You have time sensitivity and you have all these different services you have to bring in all at the same time. I don't even want to think about what that involves, but...
It's a little bit like that movie Space Cowboys. Did you ever see that?
I don't remember.
Oh. Well, you should go look that up and maybe you can advertise on your podcast. But it's a mixture of Space Cowboys and skydiving, meaning the Space Cowboys is collecting the team, which is, as Ryan said, it's probably 10 different people. And then the skydiving part is that the critical elements of the actual procedure last literally a few seconds, like a bunch of skydivers jumping out of an airplane, linking hands, knowing what to do, knowing when to release, and then jump safely to Earth. I don't know if Ryan can agree with that, but it's sort of a lot of coordination for a very short time where everything has to be done perfectly.
So that is the key. I mean, that is kind of the moment of truth. I think when the needle enters the LV, it feels almost unnatural. It feels like we're on borrowed time. And that's the critical part where, you need everybody's expertise all at one time. And it's just a very unique situation. But with effective teamwork and communication and getting to know everybody, that's kind of how it works.
I see. Ryan, larger left ventricular size was associated in your work with a greater chance of technical success. And, not having ever done this, well, actually I did one, but without really having any large experience, it seems pretty obvious why a larger ventricle would make the procedure technically easier. But I did find it interesting that a higher LVEF was also associated with better technical outcome. I'm wondering if you had any thoughts on why this might be.
Sure. My stance on this is sometimes when you're using complicated statistical modeling with a lot of interrelated variabilities, you might end up with kind of an unexpected result. And I think that's kind of what happened here. And you should try to make sense of it. And so I have a couple thoughts on how to try to make sense of that. And first, I think it's a reflection of patient selection. If you review Kevin Freeman's and Rain Tworetzky's paper from 2018 on this cohort, they found that there was a higher likelihood of a biventricular outcome if on the preoperative echo that the LV is generating a pressure, usually in the high 40s. And so, so we're likely targeting healthier LVs, at least in the more recent era. And then my second thought is, as hypoplastic left heart syndrome evolves and the LV function worsens, it's common to see kind of a hyperreflective endocardium by echo, concerning for EFE, which can stiffen the heart. And so kind of intuitively, it's easier to puncture a softer, larger LV versus a smaller, stiffer, EFE-filled LV. So that's kind of how I read with the data.
Got it. Oh, interesting. Interesting indeed. Over time, the likelihood of a technical success clearly has improved, presumably with your higher levels of experience. And I thought that was especially noteworthy given the fact that some of your favorite equipment is no longer commercially available. I'm wondering if you guys can give us your best guesses regarding what factors in the recent era would explain your lower serious adverse event rate and greater technical success rates. What do we know now, for example, that maybe we did not know when the results were not as good in the past? Maybe Ryan, you could start, and Wayne, you can finish.
Sure. I mean, for me, I started in 2015, and the program had been up and running, and so for me, it was kind of just getting repetition in a new environment without fluoroscopy. So it's not the hardest thing that we do technically, but we're definitely outside our comfort zone. And so, like anything, it just requires more preparation, review of the images as they come to Wayne, review of the preoperative images, review the images on the table, kind of have your equipment prepped and ready to go. As we've kind of, things have gone on back order or discontinued, and we've had to deal with, new cannulas, new balloons, we have to do thorough bench testing of that, just like we would if, a new stent came out and we were going to use it in our live patients. So really just having that know-how before going in. And then what's also helped is kind of understanding what the compromises are. So you're never going to get perfect images, perfect position every single time. The hearts are shaped differently. The body, the moms are shaped differently. So you have to kind of understand, all right, are we going to go around this arm, this umbilical cord? Are we going to have a shadow in this LVOT as we do this? So really kind of, get together with the team in the operating room as we're reviewing and preparing to go in, what we're going to compromise. And then I kind of alluded to this earlier. It's really just this effective team communication, as you're doing the procedure, and say what you see. That's the most important thing. Like if someone sees something, say something. Where's the wire going? I see an evolving effusion. I see the balloon's in good position. Just as it's happening, say what you see. And then, the group decision making, for the need for drugs, if you're seeing persistent bradycardia, the need for a TAP, and then potentially the need for a second attempt. So, and that's just evolved with time, as I've gotten more experience, in doing these fetals.
And Wayne, you were there really at the start. So
Right.
What would your experience suggest about this?
Yeah, no, I agree with Ryan. I think to add to that, I would say that a lot comes down to sporting analogies. Excuse me, repeating sporting analogies over and over again. But a little bit like it comes down to patient selection, which has changed over time, and our own patients with a C, not patients with a T. And so a little bit like if you use a baseball analogy, early on, we were probably swinging at at the wrong pitches in a way. For example, attempting needle access when it probably was not the ideal situation. Whereas now we really, having learned from mistakes, obviously learned from failure over time. In team communication, somebody speaking up and saying, no, let's not do this. Let's spend another half an hour positioning the baby. The same thing with, say, resuscitation. I think what we've done is earlier and earlier intracardiac epinephrine. Before, maybe we're waiting a few seconds or a few minutes to see if there's recovery. Now we just go straight for, multiple doses and early. Of course, we have less of that as the technical success has improved, as everything else has improved. And I think, again, to add to what Ryan said, is that absolute, speaking up, communication, if you think something's not right. So, for example, the wire's in and it looks like it's across the aortic valve, but it's actually in the left atrium. We've absolutely seen that. We've even seen it across the ventricular septum. And obviously, that's one of my roles, is to, as an imager, is to say, well, where exactly is that wire? Are we certain? And often we want agreement because I think, it's conceivable you can inflate the balloon across the mitral valve or across the ventricular septum because it has to follow the wire. So in that sense, not being afraid to speak up, as you can imagine, a pressured team environment, sometimes with strong personalities that are stronger than others, that kind of thing. So, and you're really dealing with seconds. This, the whole thing. I'd say the time that the cannula is in the heart is seconds to minutes, essentially.
Yeah, it's funny that there's an old saying in New York City in the subway that the police always have these signs up that say, if you see something, say something. So I guess perhaps you got that from the New York City subway. Subliminal message there.
And there are situations which are judgment calls sometimes where we need, team consensus. There's no absolute right answer. It's a judgment call. And I think that again, obviously, learning from our failures has certainly helped.
Important in all aspects of life, for sure. Well, Wayne, based on your large experience and your data, I'm wondering if you could offer for the audience, a lot of people listening do not participate in these, but certainly are in contact with you about it, maybe some comments on what you would view as the characteristics of a fetus with aortic valve stenosis who you would view as, shall we say, an optimal candidate for this intervention.
Right. So we get asked that question a lot, and I would say that the two questions we ask ourselves when we get referred a patient are, number one, is the natural history of the way that the heart features appear, is the natural history most likely to be hypoplastic left heart syndrome birth? And if the answer is yes, then the next question is, if we can open the aortic valve adequately, is there a chance that we can salvage the left heart, meaning not have hypoplastic left heart syndrome? And of course, we all know that this is not a binary disease. It's a continuum of severity, because we all know the struggles with so-called borderline left heart. There are things that are clear one way or the other, and the borderline left hearts are the most difficult. And the same applies with fetuses with aortic stenosis. There are ones that are so obvious that it's going to evolve into HLHS that they're probably also the ones that, despite an intervention, may still become HLHS, and we certainly have plenty of those, and we've learned over the years about those. And then they're the ones that actually we don't intervene on because we don't think that they're going to develop HLHS as well. So we try and get that right. To get to the more specifics of the ideal patient is obviously to get referred as soon as possible, and rather too early than too late. Meaning too early, we have ones that are so mild that we don't actually jump and intervene immediately. We say, let's see you again in a week, 2 weeks, and we will follow. And when things start to change, then we will jump. And the advantage of an early referral is that we can actually start the insurance process, the planning early on, even if we don't do it. So if we need to, then we can, get the patient there within days. So the ideal type of patient that we would say high likelihood of success of a 2V outcome is the one that has obviously aortic valve stenosis. They all have that. The higher the LV pressure, the better. The less EFE, the better. Of course, EFE is really an eyeball. Unfortunately, there's either a lot or a little or none. So high pressure LV that's still apex forming. I think once the ventricles get short, that's probably a sign already that there's been too much damage. They often go with EFE. And of course, the features that would predict evolution to HLHS, which is usually the final common pathway of progression, is usually once you get retrograde flow in the arch, and certainly dysfunction, etc., that tells you that things are changing for the worse. And of course, not all gestational ages are the same. In other words, if you're fine until 35 weeks and then you develop retrograde flow, we're not going to intervene then. Those patients are fine. We're talking mostly below 30 weeks.
Yes.
And so, it's I wish that it was as simple as plugging a bunch of criteria in, but a lot of it is sort of looking at the shape of the ventricle, the EFE, the pressure, gradients, flow directions, etc.
I see. Well, that was great. Thank you very much. I'm sure people are going to find that very interesting. The work doesn't in any fashion focus on the actual long-term outcomes for these patients, but obviously this is something that's of great interest to everyone, and it has been over 6 years since you and Dr. Friedman, Wayne, last reported on these patients, and I'm wondering if you might be able to give the audience, maybe this is an early request, but an audience of a sense of what's happening to these patients. How are these patients faring? I know that's an extraordinarily challenging question because, as you just explained, tremendous gradation between these patients, but are there any general patterns of outcomes that you're observing?
Right, so I think the most important thing is, obviously we've learned a lot from our experience. So I'd say that the patients who early on, many of them ended up with hypoplastic left heart syndrome because they were either referred too late or just presented too late, or they had technically unsuccessful procedures and ended up with hypoplastic left heart. Those patients largely, their outcome has been similar to hypoplastic left heart syndrome. So that's the one end of the spectrum, and including many who have needed to be transplanted. At the absolute best end of the spectrum are the ideal type of patient, the ones that were biventricular from birth. In other words, unequivocally biventricular from birth. I know you and I share some patients with complicated anatomy, but the ones that are unequivocal at birth, some have not even required a balloon dilation, but that's very few. And then some, Ryan and his team have taken to the cath lab for a balloon dilation after birth, and those patients have done well and behave more like a neonatal AS. I don't want to use the term critical AS because obviously that's depends. Some of them were critical, some were not.
Yes.
And those patients, many of our BIV patients have ended up with a Ross procedure. I think it's probably around, obviously, there's a lot of time to go, and our, our oldest patient is only now 22 years old. So, but I think at this point, out of our BIV cohort, which is somewhere around, I think 80 patients or so, I think about a quarter of them have had a Ross procedure, not surprisingly. And I would say all of them probably have some degree of diastolic dysfunction, as patients with neonatal aortic stenosis would have. And then there's the interesting group in the middle. There have been a bunch of patients that have had conversion to a biventricular circulation. I think that's a very complicated group of patients where that group has been quite challenging. I'd say even more challenging, obviously, with diastolic dysfunction. And there are a few new operations now which are starting to be performed more and more, the so-called reverse biventricular repair and the reverse 1.5 ventricular repair. I've only had a few of those types of patients using the right ventricle as a systemic ventricle and the left as the subpulmonary. And then the patients have had a Glenn and then using the left ventricle as a subpulmonary. And really, this is very early days, and obviously we're still learning about the challenges of that circulation. But I would say the patients who are unequivocally biventricular from birth, obviously even with needing a surgery, have done quite well, but obviously they're all still quite young. They're mostly either under 10 or certainly under 20. And so, time will tell. Obviously, our main concern here is going to be long-term diastolic dysfunction.
Sure. Well, that was great. Thank you, Wayne. Well, as those in the audience know, as I'm apt to do, I do these interviews late in the day after everybody's been working. So I'm going to finish up this wonderful opportunity to ask both Ryan and Wayne. Aortic valvuloplasty is obviously the topic of the work that you guys wrote up and presented that was published very recently. However, for those who are not in Boston or not participating in this type of work, maybe Ryan and Wayne, could you share with us, what other fetal cardiac interventions are you offering at the present time? I assume valvuloplasty of the aortic valve is by far the most common thing you're doing, but are you, for example, still stenting the atrial septum in some hypoplastic left heart patients? Are you intervening in any other diseases? Ryan, what's going on in that regard?
So, I'm at CHOP right now, and they're no longer not offering, these fetal cardiac interventions at this time. I will say that there's some exciting work being done within the institution, led by Alan Flake and Marcus Davey. They've created an artificial placenta in a lamb animal model, wow. And they're going to have the first in human hopefully this summer, with the plan to support a 20-week fetus for 6 to 8 weeks using this artificial placenta. And I bring this up because I think this provides a great opportunity for us as cardiologists to, hopefully use this artificial placenta to provide ex utero, support for potentially cardiac interventions.
Wow, so, that's science fiction. I think I remember Jack Reichik talking a little bit about that a couple of years ago. So nice to hear that something's going on there. And Wayne, since you're right in the thick of things, what other kinds of unusual, nutty things are you guys doing down in Boston?
Well, I actually just want to, even before I answer that question, I wanted to say that, Ryan kind of picked up the mantle of, he looks very young. I don't know if this is going to be video or audio, but...
Just audio.
But the, as they say, he has a wonderful face for radio.
No, that's me, not Ryan.
Oh, that's you. He was trained by Jim Locke and Audrey Marshall, who, when they left, literally he was left holding the baby. And, did an amazing job. He was probably, I think at the time, the most junior person in the cath lab, but kind of took the leadership role from the cath lab standpoint. And
wow.
But of course, we all of us basically learned from the people who trained us. And I think in his case, he was very well trained by Jim and Audrey. So just to acknowledge them, who spent the first 15 years of the program.
Sure.
The aortic stenosis is really by far the most frequently performed procedure. I think we're approaching almost 200 now. And intervention for hypoplastic left heart with intact atrial septum. We've done about 40 of those procedures. We were very excited early on with those and evolved from balloon alone to balloon and a stent. But in general, it's been more disappointing in the sense that we're limited by equipment and by the dangers of doing it. So, for example, we're using a 19 gauge for the aortic valves, right? Is that correct, Ryan? 19 gauge needle. That gets, I think for the atrial stents, we had to use an 18 gauge. Is that correct, for that long one? And that, the problem with that is that you want to do the procedure as early as possible to try and get the pulmonary veins and lungs to remodel, but the atrial wall is very thin, and so the risk of bleeding. I remember Ryan did a spectacular procedure, put a beautiful long stent in the atrial septum, and everything was perfect, and then there must have been a slow bleed, and so that, the next day the outcome wasn't so good, even though the stent was in perfect position.
Wow.
So we've been a little disappointed in that, and I think it's because of some of it is the technical aspects and the limitations in the equipment. People have started using things like laser. I think we sort of need a whole rethink on this, and of course it is a very challenging disease. We don't know if we're actually able to remodel those lungs, and so we don't do as many of those because of that, because the overall survival, despite sometimes having a small stent in place, it's not just about that. It's about longer term survival and how we can get those patients with these quite damaged lungs to get get through the procedure. And Ryan could probably speak a little more to the technical challenges of that when I'll just talk a little bit about PAIVS. Same with PAIVS, where obviously it's a much rarer condition. And the way we divide up PAIVS is really into three groups. The one is absolutely not a candidate because they have infundibular fibromuscular atresia. Those often will have RV-dependent coronaries, and the ventricle so small that it would be technically impossible, and of course there's no valve. At the other end of the spectrum are the very enticing ones, the ones that have larger ventricles, and those probably don't need it because those patients do very well with postnatal, even if it means initial palliative therapy with a balloon and a stent and surgery. But those patients eventually get to a 2V repair with the right management. And then there's the middle group, the ones that probably will need either 1.5 ventricle repair or Fontan. And that group is sort of divided into two, those that end up still needing a Fontan and those that end up with a 1.5. And it's technically very challenging because the ventricle's small, unlike aortic stenosis. And the outflow tract is stuck behind the sternum. And so it's technically challenging, and it's a rare disease. And I think we've actually done better with postnatal, I'd say understanding the disease and a sort of more aggressive therapy by the surgeons and cath people. We've got a lot of very small ventricles to grow a lot. And so I'd say that's the reason we haven't done as many of those.
I see.
But we have done. I think we've only done about 16 or 18 of those over the years.
Can you tell, Wayne, if there's RV dependency in fetal life, if it's okay to decompress these ventricles at that?
I think it's very difficult to tell RV dependency, with certainty, but I would say what makes you suspicious is if you have infundibular atresia, if you have obviously a small tricuspid valve, and if you don't have any TR, because the blood's got to go somewhere, right? And so, but I don't think it's, I think if you look at the myocardium, you see prominent sinusoidal flow with bidirectional flow. But I don't think you can tell with certainty. You have to cath all these patients. So Ryan can speak to that as well.
Postnatally, we do certainly have to cath them, unless, of course, you see atresia of a coronary, which well, listen, guys, this is an extraordinary opportunity to talk to two of the real gurus in this field, and I'm really appreciative of you giving your time to talk about this very important topic, and I want to congratulate both of you and all of your co-investigators on a really interesting and wonderful project. Thank you very much.
It was great to be here. Thanks so much for having us on.
Yeah.
Thank you very much. After this interview was over, Dr. Tworetzky realized that he had forgotten to mention a number of very important people in the Boston Cardiac Program who are involved in fetal interventions, and he was kind enough to send me this very brief audio clip in which he mentions by name most of the important players in this team. I'm going to play his comments right now, and then we'll come back to my comments about this conversation that I've had with Dr. Callahan and Dr. Tworetzky.
Although Ryan Callahan and I are on this podcast, I would like to acknowledge and thank people without whom this endeavor would not have been possible. Those people are our maternal fetal medicine colleagues at Brigham and Women's Hospital, Dr. Louise Wilkins-Haug and Stephanie Gousset, and our ultrasound colleagues, Dr. Carol Benson and Dr. Mary Fredies, as well as all the maternal anesthesia staff and, of course, nursing and operating room staff. I would also like to acknowledge and thank our fetal anesthesia team, Drs. Ariel Mizrahi, Roland Brousseau, and Linda Bulich, and most importantly, our fetal cardiac nurse practitioner, Tara LaFranchi, who makes a lot of this happen in the background. We would also like to thank all my imaging colleagues, as well as Dr. Callahan's cardiac catheterization colleagues, Diego Porras, Brian Quinn, and Jesse Ash, and of course all the referring cardiologists and obstetricians and the surgeons who have operated on many of these patients, and all the other cardiologists and ICU docs who have helped to take care of these patients who are quite complicated during the course of their treatment.
Well, what do you say when you have two of the preeminent experts in fetal cardiac intervention at the same time on the same podcast? I know that today's episode has gone a bit longer than usual, but I am sure that you are in agreement that it was certainly worth the investment of time to hear about the latest and greatest in fetal intervention from two of the true masters of the field. I'd once more like to thank both gentlemen for taking a lot of time from their schedules to discuss their work and the world of cardiac interventions in 2024. This past week, the family of the soprano Wilhelmina Fernandez announced that she had died at age 75. Some may recall that Ms. Fernandez was the star of the wonderful French film in the 1980s called Diva, and she famously sang the aria E ben ne andrò lontano from Catalani's La Wally. Ms. Fernandez was a true opera singer who hailed from Philadelphia, and I think it would be fair to say that she popularized opera for many through her part in that movie, and some have even suggested to me that my love of the great soprano Kathleen Battle even has a few similarities to the story of that wonderful film. Today, to honor the memory of Ms. Fernandez, we hear her in a live performance of Visite Arte from Act 2 of Puccini's Tosca. Thank you for joining me for this 286th episode and for celebrating our 1 millionth download together. And thanks once again to our wonderful guests. I hope all have a good week ahead.